We're now going to discuss some of the central nervous system infections, meningitis being a very common one and one that you really need to know for the exam. Again, you need to know the age of the patient. You need to know the organisms that are common in that age group. So in the first 2 months of age, always think of group B strep, E. coli, and listeria. After 2 months of age, think of strep pneumonia. Even though we are now immunizing children, still think of strep pneumonia as a common cause of meningitis. Neisseria meningitidis is a common cause in any age group, and typically it's not the most common cause in any age group, but it's common in all age groups. When you're reading the test question, something that's going to steer you towards Neisseria is, for example, a college dormitory or military recruits. Those are the two big clues that you will get when you're reading the test question, and you should start thinking about Neisseria meningitidis, and there's like basically an outbreak of meningitis from this organism. H. influenza type B is not as common as it used to be simply because we've been immunizing against it for years now. What happens during meningitis is that you get a meningeal inflammation. Most of the meningitis occurs from hematogenous spread. Don't forget, otitis media is the most common intracranial complication is meningitis. The age determines the presentation with meningitis. Remember that in an infant, they may have nonspecific signs and symptoms. Infants don't have your typical neck rigidity. They will not have a Kernig or Brudzinski's with infants because they have a fontanelle that kind of acts like a pop-off valve. So they may have a little bit of nuchal rigidity, but typically they'll just have fever, irritability. It can progress to shock. Older children will have your common typical signs like Kernig's and Brudzinski's, and those are indicative of increased intracranial pressure and meningeal irritation. Here you have a picture. It's never good to see the brain outside the body, so this is a bad outcome. And this is basically right here, all this white stuff, that's pus from meningitis. The workup for meningitis, you have to do a lumbar puncture. The diagnosis of meningitis is made on culture of cerebrospinal fluid, and the way to obtain it is through a lumbar puncture. There are some contraindications to doing an immediate lumbar puncture. If those contraindications are present, it's much better to start antibiotics and wait later until the patient, it's safer to do an LP. The LP is going to cause more problems, and you can at least start treating an infection empirically by starting the antibiotics. So if there's evidence of increased intracranial pressure, then you probably should withhold the lumbar puncture. If the patient is so unstable as far as cardiopulmonary status, they're shocky, hypotensive, tachycardic, delayed capillary refill, those are things that you want to delay the lumbar puncture. It's not going to help the patient at this point. You can do that later, but you should start antibiotics. If there's an obvious infection over the skin site that you're going to actually use for this lumbar puncture, you need to avoid that area or not do the lumbar puncture. Never, ever delay giving antibiotics waiting on your CT findings or your lumbar puncture findings. What's going to save the patient's life is antibiotics, not a CT or not an LP. You absolutely, positively need to know your cerebrospinal fluid findings. Basically, it's going to be split up into your white cell count, your glucose, your protein, gram stain. Those are things that you need to know the results of, because you can have viral meningitis, you can have bacterial meningitis, you can have what's known as a neighborhood reaction, you can have an abscess, you can have TB or granulomatous meningitis, and they give you characteristically different findings. You need to know the different findings, and you will have a table in your notes with these findings. Go over those, because the test question will give you information such as spinal tap findings. You know on the test question as you're reading it that you need to do an LP. The next piece of information is they'll give you the results of the spinal tap. Now you have to answer the question based on that. What antibiotics are you going to use? One of the favorites that they like to give as far as CSF findings is TB meningitis. Antibiotic treatment is directed at first empirically, looking at the age of the patient, and later on, once you have your culture results and your sensitivities, then you can tailor the antibiotics to the sensitivities. Remember, you're going to start for the neonate, you're going to start ampicillin and a third-generation cephalosporin, probably cefotaxime. You also could use ampicillin and an aminoglycoside for the neonate. In older children, you're going to use cefotaxime or ceftriaxone, and you should add vancomycin because there are cases of resistant or intermediate resistant streptococcus pneumonia that are intermediately resistant or resistant to the cephalosporin. So vancomycin is indicated at least until you get your sensitivities back. The duration of treatment is listed there. You're not going to get asked that on the exam, though. Other issues for treatment of meningitis includes dexamethasone. Dexamethasone has been shown to decrease sequelae of meningitis, especially in H-flu type B. Sequelae can include hearing problems, and the dexamethasone given early on seems to help decrease the development of these sequelae. Complications of meningitis include increased intracranial pressure, which can lead to herniation and or seizures. Subdural effusions are very common with H. influenza type B. These are usually sterile effusions. They will be, you'll be suspicious for them when the patient has been treated, for example, for a week with appropriate antibiotics and is doing fine and is afebrile and starts to develop fever again. Think about subdural effusions. Sometimes they need to be tapped. Most of the times they need to be left alone. Cranial nerve palsies can also occur with meningitis. The most common complication with meningitis is hearing loss. Sometimes they can have intracranial bleeding, and the irritation can also cause problems with arachnoid villi, and they will have problems with reabsorption and have hydrocephalus, but that's less common. You can prevent meningitis. We have certainly developed a number of vaccines now that can prevent meningitis caused by specific organisms. We have H. influenza type B, we have the pneumococcal vaccine, and we have the meningococcal vaccine. Also, rifampin is recommended for household contacts in cases of certain types of meningitis, especially the Neisseria meningitidis and the H. influenza type B. You give close household contacts rifampin, and it helps prevent them from getting the disease. You do need to warn them, though, that when you give rifampin, look for an orange discoloration of secretions. So the urine can turn a dark orange. Tears can also turn that color, and it should be recommended that they remove their contact lenses because it can give them that color too. Meningococcemia is specifically Neisseria meningitidis. Meningococcemia is actually in the blood. You can have meningococcal meningitis, and you can have meningococcemia. Meningococcemia is that you're isolating it in the blood. Meningitis is just in the CSF. And you can have fulminant meningococcemia, and these patients get extremely, extremely ill. Usually it starts out as a viral, nonspecific signs and symptoms, just like a cold. But then typically they'll develop a maculopapular rash. They can go into disseminated intravascular coagulopathy. Now, other organisms, like, for example, strep pneumonia, can cause DIC and a rash similar to this. But for exam purposes, really think of the meningococcus at the top of the list when they describe a patient that is extremely ill with a typical purpuric rash. You can actually scrape those purpuric lesions and culture out the meningococcus. So petechia, purpura, plus or minus meningitis is known as purpura fulminans. If it's purely meningitis, they actually have a better prognosis than if they have pure meningococcemia. Pure meningococcemia, they're super sick, and it's happened so quickly that the organism has not had a chance even to get into the CSF, and they have a worse prognosis. They can go into septic shock, and the complications are listed there. This is a child with the classic purpuric lesions of meningococcemia. Now, again, keep in mind that other organisms can do this, but for exam purposes, when they describe a purpura fulminans type picture, then meningococcus should go straight to the top of your differential diagnosis. And these are all the purpuric lesions that occur because of coagulation disorders that occur with meningococcus as part of the inflammatory response. Aseptic meningitis or viral meningitis, most of these are self-limited. The patients are sick, but they get better on their own. And the majority of aseptic meningitis is caused by enteroviruses. And so it's more of a seasonal outbreak. It happens more often in the summer and in the fall. Don't forget that arboviruses are also causes of the viral encephalitis, or they call it now meningitis/encephalitis. Arboviruses are very common for this. Arbo is basically a mnemonic. It stands for arthropod-borne viruses. So they are carried by mosquitoes and ticks. And so again, they tend to be seasonal when there are a lot of mosquitoes out, and they also tend to be in certain areas where there are lots of mosquitoes are breeding and being released, and they can carry the virus. Look for rural areas. There are a variety of these in the country. Commonly think of St. Louis and California encephalitis. There has been, however, an increase in the West Nile since 1999. Definitely need to know your CSF findings. Herpes can also cause meningitis encephalitis, and when you're reading the test question and they want you to think along the lines of herpes, always look for some kind of temporal lobe involvement. So look for a focal seizure, or they might describe temporal lobe findings on a CT scan or on an MRI or on an EEG. If that's the case, herpes simplex virus goes to the top of your list, and these patients should be treated with acyclovir. Varicella zoster can actually also cause some encephalitis type pictures or meningitis type pictures. Typically, varicella zoster presents with cerebellar ataxia. Sometimes you can see this after they're getting over an infection. Cytomegalovirus, look for someone who's already immunocompromised. They get cytomegalovirus and they can have CNS manifestations. Viral meningitis, most of these patients present with headaches. Again, remember, older children can tell you more. Younger children are more nonspecific. Infants will have irritability, maybe poor feeding. They're not consolable. Also, older children can talk about photophobia. Younger children can have fever and vomiting. And many times with viral infections, they can have rashes, so they can have exanthems. So for example, echovirus can cause this, Coxsackie virus, mumps virus, they can all cause rashes. Complications of viral meningitis, even though most of these are self-limited, they can contribute or cause Guillain-Barré. We discussed Guillain-Barré in a previous chapter. Also, they can cause myelitis and even ataxia. Most of the viral encephalitis/meningitis are going to resolve on their own. When we talk about encephalitis, look for more disturbances of function. They can actually have bizarre manifestations. The diagnosis is going to be made with cerebrospinal fluid. And the best test when you're thinking of a viral meningitis is polymerase chain reaction. So PCR is the best test for diagnosing viral meningitis. And the treatment is basically supportive unless they have HSV, in which case you can give them acyclovir.